Hello and welcome to our final webinar in our series focusing on racial inequality in maternal healthcare. For those that are new to the series, my name is Hannah Travis and I'm an associate solicitor in the women's health team at Boltwood and Kemp. A very warm welcome to you all for taking the time to join us today. We know incredibly how busy you are, so we appreciate it very much. I'm delighted to welcome today's speakers. We have Natasha Smith and Benash Nazmeen. Natasha has had several roles supporting families, including teaching in the early years and supporting children with special educational needs. After having her own children, she began working in the maternity field and has had several roles, including doula, breastfeeding peer supporter, infant massage instructor, and service user representative on the NHSE Maternity Transformation Programme. She is extremely passionate about increasing choice and personalisation in healthcare, as well as embedding cultural safety in maternity care to reduce the racial gendered health disparities. Natasha delivers training for the NHS and other organisations on anti-racism, cultural safety and wellbeing. She's also the Managing Director for the Women's Health Maternal Wellbeing Initiative, CIC, founder of Eden Script and a trustee at White Ribbon Alliance UK. Benash Nazmeen is a midwife, a mentor and new to midwifery education. She is extremely passionate about addressing health inequalities and invested in improving maternity services for those we care for and for those who work in them. She has co-designed and runs cultural competency and safety workshops for maternity healthcare professionals. As chair and director of Sheffield Maternity Cooperative, she is working to provide alternative spaces for advocacy, support and safe spaces for Black and Brown communities. She also co-founded the Association of South Asian Midwives, who work to support marginalised midwives and raise awareness of barriers faced by diverse communities. Benash is also the co-chair for the Racial Injustice in UK Maternity Service Inquiry by Birthright. She is also a specialist advisor with CQC for midwifery, leadership, quality, diversity and inclusion. And she's also just recently been awarded a fantastic fellowship with the Royal College of Midwives. In today's webinars, we're going to be hearing from Natasha and Benash on cultural safety and unconscious bias in maternity care, the historical context to this and looking at ways to improve services and outcomes. Unfortunately, due to work commitments, Benash is unable to join us live today and send her utmost apologies, but I did catch up with her last week and do have a recording of her fantastic presentation to play for you all today. After both presenters have spoken, there will be a question and answer session. So please do stay on until after we've heard from both speakers. And if you do have questions, just pop them in the Q&A box on the bottom of your screen and we'll come to them at the end. Just as a reminder, these webinars will be recorded, so a copy of a recording will be sent out to everyone after the session for those who couldn't make it today. And without further ado, I have the pleasure of handing over to Natasha Smith for the first of our today's presentations. Thank you, Natasha.
Thank you, Hannah. So good morning, everyone. As Hannah said, I'm Natasha. I'll be speaking about the historical context and backdrop towards health inequalities in the UK. So just a little bit about myself. This is important to really kind of understand the approach and perspective that I have as I go through the presentation. So as was mentioned, I worked in the earliest foundation stage before having children of my own. And then once I had children, I went into doulaing and did a few different things to support parents, such as breastfeeding peer support, sleep support, and infant massage instructor, those kind of well-being types of work. As many of you know already, that I am the founder of the Women's Health Initiative, Women's Health Maternal Wellbeing Initiative, which is a community interest company based in the East Midlands, but we support people from all over the UK. They attend our perinatal virtual hubs. So I'll be speaking about the historical backdrop to the maternal health crisis from a historical perspective. And really, for me, the emphasis here is on narrative and voice. A lot of the work that I will be speaking about stems from the research that I did in my master's. And from an educational perspective, a lot of people think that I have experience in like healthcare, but I don't. My experience is in literature. I have a degree in literature, a BA and an MA, and that's kind of the lens I'm going to be presenting today from. It will draw on, literature generally draws on history. And so there's a lot of kind of historical connections that will be shared today. So there's several places that my interest in maternal health stems from. The first being my own experience of pregnancy, maternity, the service changes to my physical, emotional, mental health as I transitioned to parenthood. Work played a massive role in my decisions around parenting, the idea of returning to work and having a career, and the tensions that exist between parenting, being the parent that I wanted to be, and actually having a career. And so a lot of the time when we think about maternal health, it needs to be shaped and framed within some of the kind of wider issues. And my experience isn't unique. You know, my story can literally be something that another person can tell. And I've had similar experiences to my own when it comes to the experiences of early parenting, work, and maternal health. And one of the things that came to me in my kind of early postpartum experience was, after having quite a traumatic birth, I remember this day where I think it was actually in the evening, and I was holding my son, and I remembered thinking, what have I done? Why have I brought a child into this world? And at the time, it was around the time when there was an increase in people documenting the violence around youth violence and knife crime, particularly around young Black boys, and also the filming of the police brutality that was happening in the US, and some of the really big, cases that made it into the media at that time. And I just remember having this sense of terror, thinking about bringing a child. Obviously, I had no control over the gender, but particularly having a fear and a worry about raising a Black boy in today's society. In addition to that, my own personal experiences as a teenager, and I guess the beginning of this crisis with youth violence. My friend lost her brother, and my brother lost a friend. And that really stayed with me. You know, that was a very traumatic experience, not just for me, obviously for the family, it was a horrendous thing to go through. But I remember that the emotions and the aftermath stayed with me for a very, very long time. And it came up in my maternal experience, the moment that I found out I was having a boy. And I was really confronted with that once he was here. And then from then, I had other experiences thinking about my own ancestry. And I had this realization in this moment that had I been born just a few generations ago, you know, my experience as a mother would be very, very different. It made me think about my grandmother's experience. My own experience made me think about my great-great-grandmother, her mother, and those experiences. And often, a lot of the time, we don't really connect ancestry to the idea of family. But these were my relatives I was thinking about. And for the first time, I had shifted my thinking about ancestry into more in line with the idea of family, and really thinking about how connected I was to the generations before me. And so some of this thinking underpins a lot of the work that I do through the initiative, and understanding people's experiences, but also understanding the kind of legacies around health inequalities. So one of the things that I looked at when I did my MA was slave narratives. And I was really interested in understanding Black women's voices and Black women's narratives. I wanted to understand, I wanted to get as close as I could to their experiences. And there was a personal interest, because in a way it was helping me to find, in a sense, my own connections to my foremothers. But it was also helping me to understand the context in which I was living and how there's this connection. I could see the connections, but I just wasn't able to articulate those connections. And so one of the narratives that I looked at was the history of Mary Prince. And Mary Prince, her biography was the first to be published in Britain. It was published in 1831. And it was published at the time, the height of the abolitionist movement. And since no female first-hand account of slavery had been told, Prince's text was significant at that time. And it was actually instrumental in some of the changes, particularly the abolition of slavery, because of the way in which the story revealed the experience, the personal experience, and also the fact that there was evidence of the harsh and inhumane treatment of women and children, literally on the physical body of Prince, which was examined and verified. So the fact that there was these bearings on her body, these physical signs, and it matched the things that she had been saying, it really confirmed the hostile environment and the inhumane treatment of enslaved Africans. The issue that I found when looking at these texts was the idea of authenticity. For example, another narrative called Gabriel Stedman, written by Gabriel Stedman, who was a soldier who went to quell the revolts in Suriname. His narrative underwent several changes, and it didn't really reflect the original. And all of these nuances are the things that interest me. Another person is Phyllis Wheatley, who was a young Black writer. She was an enslaved woman. She was enslaved as a child, and she produced these wonderful pieces of poetry. But even her ability was questioned, and she underwent a rigorous examination by several men, notable men. It's quoted as in Boston, to not just validate that she actually wrote those pieces, but actually it was connected to her being seen as a human. So her humanity was also in question. And so there's all these intricacies that interest me when we think about narratives and voice from the historical perspective, but also there's nuances when we think about it today. So just a little bit about Mary Prince. She was born in Bermuda in approximately 1788, I'm not exactly sure. The narrative was published in 1831. And one of the key events in the narrative was Prince's separation from her mother around the age of 12. And she recalls this event with, great distress and grief, which was a large feature in slave narratives. And it was one of the main things that contributed to the arguments in favor of ending the slave trade. But one of the stories in the narrative that really interested me and caught my attention, particularly thinking about Black women's health today, was this person called Hetty. And Hetty was an enslaved woman. When Prince was removed from her mother, she joins this new family. And one of the servants there, an enslaved woman, was Hetty. And Hetty really forges this relationship with Prince, maternal in some ways, like a kind of kinship relationship. And she looks after Prince, she takes her on. That's one thing. One of the other things is Prince drawing attention to the double burden of domestic and field labor that was assigned to enslaved women. And not only that, but Prince here highlights the kind of protracted and endless work of enslaved women. So here you can see a quote where Prince describes Hetty as the most active woman she had ever seen, and she was tasked to her utmost. And then she goes on to describe the tasks that Hetty had to do. And what we see here is that her work was near impossible to complete. And what I think about here is the massive effort that Hetty would have embarked on to achieve these goals, but not only the effort, but the stress and the fear that may have characterized how she worked. And so this is really an important insight when we're thinking about Black women's experiences. Sorry. So one of the other things is Prince's attempt at her own freedom. Prince's freedom doesn't come about suddenly. Over the course of the narrative, Prince speaks about her own freedom, her desire for freedom, and how she sought to achieve that. Prince again points to her own productivity, her own desire for being autonomous in a very, very restrictive society. So for Prince, she talks about growing food and selling the food to purchase her freedom. But of course, for her, there were other barriers. Prince couldn't just buy her freedom, it had to be given to her. And so when she does actually become free, what's interesting to note is that her freedom from slavery is actually tied up in her freedom from ill health. So Prince actually, throughout the narrative, complains about this kind of physical ailment. She has this arthritic pain. And when she hears that her owners are traveling to England, she asks that she can go with them so that she can get medical attention. And so when Prince travels to England, once she kind of falls into the hands and the circle, the social circle of abolitionists, they are supporting her to, become free, because in England there was laws that when you're there, you technically could not be a slave. And so using the kind of levers that were there at the time, Prince was able to gain her freedom. But I find it ironic and interesting that if Prince hadn't used the premise that she needed medical attention, would she have been able to gain her freedom? And what's also interesting to me is that I wonder, and I often think, did Prince know? Was she aware of the ways in which she could achieve freedom? And did she actually, in fact, use her health as a means to obtain freedom? And so this really speaks to the strategic efforts of Prince. So in summary, just for the sake of comparison, what I'm getting at here is the effort, the massive effort required to overcome the harsh working conditions, particularly in the case of Hetty, the protracted and harsh work conditions, the violence of the society that she lived in, the double nature of her labor, and those issues. For Prince, but also for Hetty, the kinship was also an important strategy in their survival. Prince's self-determination for freedom was important. Understanding the movement and displacement and the challenges that come with that is also important, and understanding the efforts to overcome, the ability to gain her freedom. And so for me, histories is emblematic of the effort against the challenges that Black women often try to overcome today. Many of the legacies of not being seen as human, as not being seen as equals, still remained once the slave trade had ended. When my grandparents came to England, they entered into a hostile and racist environment. And so this, was really a direct legacy of colonialism because a lot of the tropes and narratives around Black people was used to justify the slave trade and slavery. And there wasn't a real effort to humanize Black people and other people from the previous colonies. And so today, often we see, particularly in medicine, tropes surrounding Black women as being poor mothers, absent from her family, kind of like this neglectful person. She's kind of doomed as she doesn't and doomed as she does, because if she's not with her family, she's blamed for any kind of other needs that the children might have or behaviors that the children might display. And then when she does decide that she doesn't want to work, she has to worry about being deemed as lazy and somebody taking resources. So these are some common challenges and tropes that Black women often have to contend with. And so for me, we can learn from these narratives about this historical connection to environment, racism, and health, and particular stress. So one of the things that was really interesting is that I was obviously doing a literature-based research project for my MA. And, I was hoping to understand those lives and then later kind of apply the learning to support the work that I do with Black women. And I hadn't come across anything that really spoke to these ideas that I was having. And I'm really fortunate that a colleague of mine, Princess Banda, who's studying now at Oxford for her PhD, introduced me to this really interesting concept called the Sejuna Syndrome, which was coined by Leith Mullins and her team. And it really speaks to the historical context to which we belong and what we can connect to. So thinking about Prince and the example of Mary and Hetty, that legacy really forces us to grapple with how it shows up today in society, the historic racism, structural violence, discrimination, social inequity. It forces us to interrogate how gender, race, and class intersect and relate to health inequalities. And so taking the example from Leith Mullins of the Sejuna Syndrome is really interesting because they coined this term based on the life of Sejuna Truth. And Sejuna Truth was born in America, and she was born into slavery. She lived the majority of her life in slavery. And during her life, like many other slaves, she endured hardship, violence, sexual violence. She was separated from her children. Her children were taken from her. She speaks about having 13 children and these children being taken from her. And she spent a lot of time speaking up for herself. And she has a piece called Ain't I Woman, which you can look at in your own time. But she speaks about her experiences in this speech. And she also speaks to the fact that, she was really opposed to just the severity and the inhumanity of the slave system. After Prince became, so Prince was able to gain her freedom. And when she did become free, she became an itinerant preacher. And she went about speaking to white people and the need to oppose and end slavery. So for Mullins and her fellow researchers, truth was the perfect symbol that embodied the constrictions of the life of Black women in their research project here called the Harlem Birthright Project. But it also spoke to the ways in which women would kind of modify their behaviors in order to resist some of the hardships that they were experiencing. In addition to that, it recognized a massive effort that was required to overcome those barriers of deprivation, discrimination, the unequal distribution of resources, explicit, forms of racism and other forms of oppression, and the health consequences of doing so. So in short, basically, the harder that they worked to overcome the barriers, the bigger the impact was on their health. And oftentimes we think about this in the context of toxic stress. And so, you know, there's Dr. Williams, Dr. David Williams, who's done a lot of work with the NHS on this. And he speaks about the role of racism, everyday racism, and how it leads to disease and sickness. It makes people sicker and it makes people age faster. And this can also be linked to the concept of biological weathering as well, where the body is basically being broken down by the everyday discrimination and stresses. And so this is a really, really useful concept that we can apply, particularly in the UK. When we think about Sojourner Truth, obviously a lot of the time people say, oh, it happened on the soil in the US. The problem that people find understanding the impact on Black people who are in the UK is that a lot of the slavery happened overseas. So what I hope is that looking at Prince and Hetty's experiences really helps us to understand, actually, even though it happened overseas, there were still implications for home. When we're thinking about the UK today, a lot of us come from families who were a part of former colonies. And in birth, we recognize, you know, that you inherit the health of your mother. So there's that to think about as well. And I think it's important to think about the fact that Black women tend to be overworked. They find themselves in jobs that are insecure. They might be in jobs that are the kind of first to go when there's a budget cut. We know about the disparities in the gender pay gap and the kind of additional layers that occurs when race and ethnicity are involved. We know that women who might take top roles in companies, Black women, are forced to take lower pay than their white counterparts. And a report came out about that recently. So there are these stresses that are usually not really named, and we have to go to great lengths to name them, to prove them, to say like these things are affecting our health and well-being. What's important about this work by Mullings was that it really served to dismantle ideas around you know, the reasons are genetic, the reasons are behavior, the reasons are cultural practices that we have, you know, these things as reasons for why we're sicker and we're dying earlier than other people. It really challenged that notion, and it highlighted and it named the real issues, some of the real underlying issues. What's also important to note is how kind of the finer details here, which I've put on this slide here. She highlights that in the Harlem Birthright project, which looked at different communities within Harlem, that one of the issues were things like housing, you know, poor management, not good quality housing. When they did do repairs, they weren't done properly, so they were insufficient. These things kind of led to like rodent infestation. The communities tended to be, you know, violence. And one example of a violent episode was directly linked to a participant who experienced an infant loss at 5 months. So there was all these kind of issues that were being named in this study, which was really, really important. But what was also important was how they manifested across different socioeconomic statuses. And they looked at middle earners. And what they noted was that these people were actually more exposed in their jobs to racism and discrimination. And so the impact of that obviously increased their stress levels, which also had a detrimental effect on their health. And so this was really an important finding, particularly when we're thinking about the UK. A lot of the kind of issues can easily transfer and apply here. We see similar findings that even, you know, once you go up in a socioeconomic status, that you're still more likely to have an adverse birth outcome. But this study didn't just focus on the kind of problems. It did highlight some strengths and some really interesting concepts, which was how people felt about their community. It highlighted the effort that people put in to, I guess, provide a buffer for the experiences, but it also helped them to highlight the importance of kinship and the ways in which women work to almost counteract the effects of racism. So solidarity, community, taking up the mantle for themselves. There was community organization, which was really important. So people took the landlords to housing courts. They often actually represented themselves. But the correlation was that although there was this organization, it was really, good and empowering for the other people, actually it did have health consequences. And so this is the kind of context that I want us to think about when we think about Black maternal health in the UK. As I mentioned before, a colleague of mine, she's doing some amazing work on stress and the role of stress in Black women's health. And she really says that, we ought to think about this in the context of austerity, the racial gendered pay gap, and other social inequalities. And Marmot's report really touches on some of these inequalities and their lasting effects, not just for that person, but actually on generations after. So thinking about housing, we know that housing is a massive issue. Pollution is a massive issue, particularly for Black, Asian, minority, ethnic communities. Racism in the workplace, bullying and harassment, the gender pay gap, racism and biases in education. Children are experiencing that at a young age. It's often, we only think about it often in the context of adulthood, but no, children experience it in education, which we've, there's been a big story in the news recently about this with Child Q. In addition to this, the policing within Black communities, or over-policing, and the overuse of stop and search, these increase stress, and there's a massive effort. We see this all the time, people organising to raise awareness of this, to ask for changes to policies, to ask for better policies. Massive amounts of effort goes into challenging these issues. And so when we think about healthcare, we need to think more broadly. It's not about saying to people, we want you to eat better, we want you to go and get more exercise. They might have some general health benefits, but they will never, ever be able to counteract racism. And so here are just some examples of some of the stories that we've seen around the issues that have a really negative impact on people's health and well-being, and that cause high levels of stress, and in unfortunately some cases it can result in death. So thinking about race and racism and health, there's a lot of talk about being inclusive. We're hearing a lot of terms being thrown around, and decolonization. And these terms are just not a substitute for dealing with racism. It's not a substitute for tackling racial health disparities. It feels like a lot of people are still afraid to speak about racism. A lot of people are afraid to deal with racism. But if you're not prepared to talk about it and talk about the root cause of health inequalities and racism as a factor, it's a bit like pouring water out of a stinking boat with holes in and not plugging the holes. You can't tackle racism without addressing racism, and that means you need to start talking about it. So just some reflections from me about what you can do. Listen to Black women. We do speak, we're just not listened to a lot of the time. We are organisers and we are organising. So become familiar with our work, listen to us, be an advocate and be practical about that. Speak up, but use your power, use resources, use your networks to amplify the work that we're doing, to give us the platform to speak about, the work that we're doing and the issues that we face that do impact our health. If people listened more closely, we'd be a lot closer to finding the solutions. Be specific. understand the unique challenges affecting people who experience anti-Black racism. When we look at the Embrace report, there is a sliding scale of colour. The darker your skin, the worse your outcomes, and we need to pay attention to that. BAME is a very broad term, and oftentimes, you know, when funding, for example, becomes available, Black women, particularly Black British women, are often excluded from the benefits of those resources. We need to be intentional and avoid tokenism. It shouldn't be, we shouldn't be an afterthought. You know, we're not there for a tick box exercise. If you invite us to the table, show the respect, acknowledge the strengths that we have, the knowledge that we have, the skills that we have. Understand how, when you ask us to participate in your events or your meetings, that you actually might be taking us away from very important work we're doing, and therefore you could be increasing, you know, stresses. Make sure that that work that you ask us to do is adequately resourced as well, and don't take for granted the ways in which that could actually negatively impact us, particularly in environments where there is a culture of not listening. Read, watch, and listen to literature, information, research outside of, you know, specific health literature. I think it's really important that people take ownership now over widening their own knowledge and understanding the historical context and the historical links between health inequalities, colonialism, and ethnicity. I think that people need to challenge what they don't know about race, challenge what they do know about race. Don't remain ignorant. It's time to inform yourself. There's so much resources out there. And remember that Black women, we lose the apparent benefits of improved class status and gender protections that other, you know, women, non-Black women might have, and particular Black British women. And I found this in my own kind of work when I've looked for funding, for example, to do some of the work that we want to do. Actually, a lot of funding requirements exclude us as a group. So, for example, where there's gender, funding around gender, we're typically excluded from that as an organisation, our not-for-profit organisation. And then where there's things that kind of link to ethnicity, we're often excluded because a lot of the resources are geared towards asylum seekers and refugees, which rightly should be, but it means that there isn't actually anything that helps to tackle the issue of health disparities amongst Black British women, or at least they're hard to find and they're very few in number. And get personal with reflexivity. You know, it's an approach that researchers use in anthropology. Examine your own beliefs and your own judgment, your own practices. Think about yourself in this dynamic, particularly healthcare professionals and those, you know, trying to invite people to sit at the table. You know, what are you bringing to that table as well? And lastly, you know, just touching on cultural safety. I know Elsie has spoken about this already, but actually thinking about the taken for granted power structures. Think about that. Think about how resources are distributed. Think about how you as a person in interaction with Black women, think about how you affect that relationship. You know, if someone comes to you and they talk about their pain, they talk about their needs, you know, are you actually listening to them? Are you making assumptions about them? Are you blocking them from being referred and getting the help that they need, further assessment, or just general medical attention? So really think about your personal interactions as well, and don't take for granted that the power structures that may be at play in your personal interactions, but in maybe your wider role and capacity too. So my final thoughts are really that, you know, Black women, we are doing much of the work to uplift our communities, support one another, educate and bolster our families and local communities. We are working cooperatively with each other. We work and we strive to be collaborative. You know, we are always seeking support and connection and collaboration. And I think it's important for that to be recognised. And what that also shows is that we have the solutions, that actually it needs to be that people are engaging with us. What we need is more power and resources so that we can support ourselves, our families, and our communities, and to have our solutions implemented. And so, those of you here today who may be not just a healthcare professional, but maybe you're here from the private sector or a different area, think about your own organisation and some of the things that have been said today. What's the culture like within your organisation? How could you be contributing to weathering? How might you be really, not reducing the stresses, or you might be contributing to the stresses that are making people sick, whilst at the same time saying, hey, we want to do things differently. Are you actually doing things differently? What are you doing? And have you engaged in a meaningful interaction with your Black female workers? So for me, I just want to kind of end on a note of saying that we are doing much of the work that needs to be done. So engage with us and don't take our narratives and our stories for granted. There are, gems in the wisdom, the knowledge, and the narratives that come from us. Thank you.
Thank you so much, Natasha. That was incredible. For those who have questions for Natasha, please pop them in the Q&A box and we'll come to them at the end. So I'm now going to show the second of our presentations today from Benash and Nazmeen. I'm going to share my screen with the recording, so please do stay on the end till the end so we can ask questions about that as well. So bear with me just one moment and let's get this rolling. Okay.
Hello, thank you for joining me, and thank you to the team at Bolton, Burden and Kemp for inviting me to speak. My name is Benash Nazmeen. I'm a midwife. I wear various hats, which I'm going to touch upon a few of them historically and currently around health inequalities. I am here today to look at and talk about the racial inequalities and injustice we see within maternity services, but from a slightly different lens. I know my colleagues have been on before and spoken at length about some of the issues already. So today I'm going to be talking about how we can start moving towards addressing those inequalities, how we can start beginning to reflect upon our own personal biases, review systemic issues, and how all of us can start working towards actively addressing those. So welcome, and let's start with the concept of cultural safety. So what is cultural safety? Now, it can be quite difficult for people to understand what cultural safety is. And Natasha's going to be talking about historical events later. But what the reality is, it's the historical events that lead to the current state of affairs. So cultural safety actually originated in New Zealand, where the Maori people, who are the First Nations people or the first people of the country, were being seen to have adverse outcomes when compared to their counterparts. So in reaction to this, the Maori nurses wanted to actually start working towards understanding and addressing why these inequalities existed there. And they thought of the concept of cultural safety, because before that, historically, there was a real importance placed on cultural awareness, which was knowing that actually, there's differences in myself and the person I'm caring for. We're from a different culture. Our behaviors are different. The barriers we face are different. The lens we look through are different. The experience we have is different. And trying to be culturally aware was trying to be aware of how someone's culture may affect the way they present or talk to us or ask for help. And it's not necessarily enough to be able to be culturally safe, because understanding there's a difference is only the first step. They then realize that actually knowing there's a difference can lead one way or another, which is it can either lead to cultural sensitivity, which is almost when you're leveling up in that game and you get to cultural sensitivity. So you're conscious and alert of differences, and you're starting to explore how the power dynamics may exist in this caring procedure or in this process, and how it can impact on them. So you're being conscious and sensitive towards them when you are caring for them. Now, this is a great step because it means action is starting to take place, but it's a process and we cannot necessarily get there straight away. And the reality is that despite some people being aware and sensitive, they weren't being culturally safe because they were still perpetuating behaviours that was not conducive to equitable care. They were still going off their education, which was based upon a Eurocentric or fair-bodied lens. They were still perpetuating biases that they had either been exposed to in their life or earlier, and even within the education, within the workforce. And what cultural safety is actually not just being aware that there's differences, being aware that your privilege means that you do not or cannot understand what those differences are, and then actively trying to stop that from impacting the way you care for someone. So it's almost like a little bit like a checklist of being aware of your initial assumptions and prejudices that come to you when you see a name or you are handed over someone and they have been given negative connotations, have been presented in handover. And then when you go into care for them, knowing that even though that you've heard that, you're not going to let any of that impact the options you provide, the information you provide, and the way you provide that information to the people you're caring for. An example here would be for if someone had mentioned that a particular person is living in a multi-generational household, and therefore I'm not going to provide home birth, or I'm not going to provide as much detail about home birth because they won't want to give birth at home. And I have actually experienced this. My first time I experienced and heard this was when I was a student, and therefore I didn't challenge it at that time. And it's quite difficult looking back in my career and reflecting upon times when things I have done has probably not been the best care or the best evidence-based care. But what I can do is know that in the future, I won't let those things affect me and the way I present information. And if I'm going to care for someone who lives in a multi-generational household, I'll give them all the options and inform them of all their choices and inform them why that's beneficial. Because my grandma was a village midwife in Kashmir, and my mum had all 6 of us in the mountains in the middle of nowhere at home, because the closest hospital was kilometers away and we couldn't get there. So actually, it's something that's traditional in my household. So why wouldn't I, even if I am living in a multi-generational household, want a home birth? I know I would. And I know that if someone didn't present me the opportunity, I wouldn't have that option. And we also know the implications of what can happen, an intervention increase that can happen if you're just placed in a hospital. So the concept of cultural safety is exploring our privileges, understanding how that privilege affects us, understanding how we can sometimes become only exposed to our way that centralizes us, which is the majority, and how that actually impacts people outside of the majority. As a female, as a Muslim, as someone who's quite outwardly melanated, as someone who's neurodivergent, I face, issues in different aspects of my life and different problems on a daily basis, which are barriers for me, but not for people who don't have any of these issues, who at this point is a white male, but we won't go down that road right now. So really, there are also other marginalized groups that I know little about, but I am currently learning a lot about, so that I can step outside of my echo chamber and step outside of my experiences and be able to be present and vocal and support them when they are being marginalized or suffering or going through problems. I am making friends with a growing community of LGBTQ+, or my friends, as they like to call themselves, the queer crew. And I am understanding what kind of issues are coming up. I am reading books. I am exploring things because, it's quite easy. If we have a question, we go online and we find the answer out very quickly. But this is much more complicated, and this needs much more concerted effort than just searching something online. So cultural safety, I can only introduce to you today. This is going to be a long journey to get there. And then as we evolve as a society and as things grow, it's going to be a continuous journey. Just like we have to do continual professional development as midwives, we have to have continual professional cultural safety development too. That's a mouthful. So we can care for everybody with equity and hopefully achieve justice in our care. Now, the concept is very large, and you will hear lots of terms and terminology around this. We have lots of cultures. Everybody has a culture. Everybody has a way that they see and view life wherever they are, however they are. We have traditional views, we have contemporary cultures, we have, what our focuses, values, beliefs are, but also the complex kind of understanding of how we got there. What is the lessons we learned from the ancestors before us? What have they taught us? And are those lessons impacting us now? There's a very real concept of intergenerational trauma, and people who have had to survive through very tough experiences in their life, teaching their children how they survived through those hardships. And those lessons are not necessarily true for the younger generation. My example is, I grew up with parents who didn't speak English when they came to the UK, who weren't literate in the sense when it comes to English. They were multilingual. My dad was multilingual, but he taught me lessons like keep your head down, don't question authority, don't rock the boat, work harder than anyone else. And that was because they were all things he had to do to survive, because he was going through life at a time when there was quite open outward racism. I am blessed and I have the privilege of going through a time when racism isn't as open or as outward, but it's more microaggressions. And I had to overcome and unlearn some of those lessons that my dad taught me, because I have the privilege that I can speak up and speak out, not just for myself, but for other marginalized groups and other people who are having poor outcomes and poor experiences. So knowing that cultural awareness plays a part, and sensitivity and knowledge, they're all small bits, and that's all within the middle. But cultural competence and cultural safety are focusing on what we as practitioners are doing. How are we understanding? How are we providing knowledge to professionals? What are we training them in? And how is that then going on to understand the cultural customs and social detriments to health and the effects of colonization within the generation we're looking at? Because the trauma has come from as far back as when we were colonized. Some of the behaviors of trauma, which are addiction, which are comfort eating, which are the kind of violence, domestic violence, mental health, anxiety, depression, exist quite evidently in our communities, but aren't necessarily supported or recognized as effectively because they present in a different way or in a different manner. Mental health is a primary example. You know, unless I go to the GP and I say words like I'm anxious, I'm nervous, they may not necessarily pick up mental health as a problem for me straight away. Whereas when I was growing up, I didn't necessarily know about mental health. I didn't have mental health literacy in my community, in my language. There's no word for depression in Urdu. In many languages, there's no word for depression. And if it's this taboo subject presenting, where you go and ask for help, you're talking more about things like palpitations and psychosomatic symptoms that come with mental health, so you can understand how far down the spectrum someone is if they're complaining of palpitations and migraines and headaches. And as clinicians, when we can't clinically diagnose it after doing all the tests, we actually think people are malingering. And this concept of us not listening is because we think people are malingering, and that's not the case. We just aren't recognizing the problems because we are not understanding how they present. So that is cultural competence. It's knowing, understanding, building, and recognizing our lack of awareness in the situation so that we can gain that awareness and be able to be competent in caring for people across. And it doesn't mean that you know everything about everyone. It means that you are curious in the way you talk and the conversations you have, and you take time to understand, and you take the time to call the interpretation services if you need to. And if they are not proper, you rebook the appointment. And if the 15 minutes appointments isn't enough, then you make sure you have longer appointments, because equitable care isn't the same as equal care. Giving everyone 15 minutes is not enough. Because when there's an interpretation service involved, or when there is someone with learning barriers involved, then that 15 minutes may as well be halved. And 7.5 minutes for an appointment to give all that information and have all that conversation isn't enough. So that's a systemic problem. So we need to challenge that. And that's why continuity is being supported in this regard, so that continuity of care can support building that relationship, building that understanding, so that this person who's in front of it doesn't have to explain every single time to a different clinician what is happening to them, because sometimes it's really difficult to talk about. And then it kind of builds to that. It builds to the cultural safety. It builds that kind of space where people feel safe. They see that the power isn't between the authority figure and them. The power is combined and it's balanced. Culturally, safety is also, the word safe is making sure that we address that power imbalance in our caring. It's making sure that we reduce our impact to people in a negative way. It's about being aware of the threats that are structural and personal and sometimes unconscious to this person, and actively preventing that from affecting the care. So that was a confusingly, mind-bogglingly basic introduction. This is a brilliant, piece of a diagram that explains or tries to explain it, but there's lots of work around this. And actually, I would suggest everybody take some time to read upon this more and try to understand how we can all become culturally safe practitioners. I had to go on this journey myself. I went for a job interview back in 2020 and started a role as a cultural liaison midwife, which at the time when it was advertised was BAME lead midwife and community lead midwife. And I went to the interview and realised that these are two different jobs and I can't give my 100% to either of them. And I was very much interested in addressing health inequalities. So when I brought that up in the interview, they liked the fact that I challenged that, and the amazing team gave me an opportunity to create my own job. So we changed the job, and the first change I made was change the title, because I don't want to talk about being a midwife for Black, Asian and mixed ethnic heritage or minority ethnic people, or how does even someone say that properly without looking down and feeling ashamed? Because I feel bad when I say it out loud. So trying to explain that was going to be difficult. So I did something called co-production. I reached out to various professionals and people from varying communities, and I said, what kind of title would you want a midwife to have? What kind of title is important? And this is my role. I'm looking at health outcomes. I'm looking at health inequalities when it comes to race and ethnicity. And I'm trying to make sure my role title isn't scary. So we had lots of ideas. In the end, it kept coming back to the concept of cultural safety. So I didn't want to have cultural safety in the title because some of the feedback was that, safety makes us feel unsafe because you're almost saying that you're actively trying to stop us being from unsafe. So in the end, I became the cultural liaison midwife. Specialist cultural liaison midwife became my role, because what you're trying to do when you're liaising is you're building bridges and you're filling in the gaps, and you're trying to make the links between the cultures. Everybody has a culture, and that's what co-production is. It's a relationship, it's a sharing of power to deliver something that's recognized by both sides and that can improve both the way both sides interact with each other and improve the systems and services that we provide both ways. And it starts from the beginning. It starts from understanding the principles of co-production. Now, we hear that things have been co-produced, but has it really been co-produced? Was there equality amongst everybody who was there? And actually, equality isn't enough now. It's about equity. Did the people who needed support with childcare, did they get support to, have childcare so that they could attend this meeting? Or did they have, digital access so they could log on to Zoom so they could attend this meeting and give up their precious time to make and improve our services better? Is it representative? Do we have diversity? Do we have all the people in this session, this meeting, in this safe space? Are they all people who we care for? And if not, who's missing? Is it easy for them to access? is accessibility possible? And are we reciprocating back as well? Are we reaching back out to them and providing them and, you know, telling them that what's happened? Because we can't just take from them, we also have to keep them involved and let them know what's happening and give them feedback and see that their valuable time has led to this change, because that's how you build relationships. Right now, a lot of Black and brown bodied people are exhausted and tired because they've been audited and researched and, you know, interviewed and X and Y and Z, but they aren't seeing what's come about on the back of that. So when you are asking for their help and their support, are we not just supporting them to be there and paying them for their time of being there in whichever way is feasible to us, but are we also going back and saying, look, this is what we've done on the back of what you've shared with us, thank you for sharing? That might encourage them to encourage someone else to do that in the future, or that might encourage them to continue supporting in the future. It's so important that we value co-production and that we give them that power, because if we're talking about cultural safety, it starts with the planning of services, it starts with the development of services, it starts with the quality improvement projects that we have that need to be presented and represented. I know we have amazing MVPs and I know they are trying their best to get representation on board, but sometimes it's not always feasible because people who are trying to survive don't necessarily have the time to give without being, you know, compensated for their time if they are just trying to get through day by day because of difficulties. So when I started my job, I wanted to understand what was going on before I could start with co-production. So it's really important that we first lay down and understand our demographics. We identify and understand the needs of the demographics as well as our workforce, because we have marginalized members of our workforce who would be assets to supporting the work we do. But if they're not in those spaces or they're not supporting this work, and people are making decisions about groups of people they know nothing about, then we're going to make mistakes. So, for example, when COVID happened, we saw that adverse outcomes were happening more in Black and Asian communities. As someone who's Asian, I've disconnected from mainstream media a long time ago because I am tired and exhausted of seeing things that either describe me negatively, describe people around me negatively, or only marginalized people who look a certain way. And therefore, I'm not following the mainstream news channels and media, which is how most of the COVID news was pushed out. So did people not get the accurate news at the best time because they were getting it delayed? And we know things were changing minute by minute. So if they've got news from yesterday and things have changed today, of course, the people who are the last to get the news are going to have the worst outcomes. And who was making those decisions? Were they representative? And if they're not representative, why are they not representative? Because the NHS is meant to be the most diverse workforce we have. So, you know, what's happening? How do we identify the needs of the services we're caring for? And how do we ensure that the right people are invited? And how do we recruit them? And on a regular basis, like any good audit, you're meant to come back and review these things because your demographics may change, your workforce may change, the needs of your demographics are going to change if your demographics have changed, and therefore the people you need to invite to the next session need to be representative again. The way I did this was I looked at various different factors. I looked at indices of multiple deprivation. I looked at and gathered data on all the key performance indicators. I wanted to have the key performance indicators in front of me so that I could see what the outcomes were, not just for, maternal death, neonatal death, stillbirths, but also for breastfeeding, also for tear rates, and all these things that we have on the dashboard that we have and that we look at. I wanted to know them, but then I had other questions like, well, who's not attending appointments? Why aren't they attending appointments? Who's not attending appointments after a 3rd or 4th degree tear? If someone's had a OAC or a obstetric anal sphincter injury, why are they not getting follow-up care? And I then broke it down into the indices of multiple deprivation. I looked at gender and age, broke ethnicity down more than just one, because, there's multiple factors here. There's multiple biases involved. So I looked at languages spoken, country of birth, postcodes, and how this was spread across those postcodes, and broke it down also into wards. I went to the local authority, spoke to them. I got data around what is the average life expectancy for females in this area, because it's wider than just maternity. We know that if someone has unaddressed pelvic concerns, that can affect their physical health in the long term, also their mental health in the long term. And if that goes unaddressed or is poorly addressed, that's going to affect their life expectancy in the long term. So what is a life expectancy? And what are the years of ill health? Because if they've got shorter life expectancies, what are the years of ill health? The Office of National Statistics in 2018, if you get a calculator and crunch the different kind of factors, you can calculate that a woman in a socioeconomic deprived area who's white British has an average of 10 years of ill health. But in the same area, someone who's from a Black, Asian, or diverse ethnic background has an average of 25 years of ill health. That's disproportionate, massively disproportionate. And as Mars beautifully said yesterday, or the other week even, that we have to stop saying that it's socioeconomic and comorbidity factors, because it's wider than that. And Christine Akechi also said that as well. So we have to start looking at the wider issues. And then I wanted to know, well, what are the gaps in this data? What isn't here? Why are we not collecting that? What's going on? So I had lots of questions. I was very annoying for about 3 to 6 months, and people were sick of me knocking at their doors, just being nosy. But that led me to understand the demographics. That led me to be aware of who my pregnant population was in this provider, and what their needs may be, and where the barriers may be coming up. So I made a wish list based on that, and based on that wish list, I made a recruitment plan. So I had the conversation with all the community midwives, because I knew my MVP at that time was not representative. So after community midwives, I said, I really, in this postcode area, because of course, all of it, by looking at all the data, I was able to find that there was one postcode area that had the highest migrant community, high levels of socioeconomic deprivation, poorest outcomes across the board for various things, and also had significant issues in other areas too. So I wanted to do a targeted approach. So I went to a postcode area and I said, okay, I need this community team to recruit at least two members from community A, 2 members from community B, 2 members from community C. And I also said, I don't just want people who are English speaking. I want first and subsequent generation, members. We had people who weren't able to communicate via digitally. So we did digital sessions on Zoom because obviously COVID. But then for those who had to have it in person, I either did one-to-one phone calls with an interpreter or had a one-off focus group session with them in a place that they could access to get that information, because we need to move away from saying people are hard to reach. Because once we stop saying they're hard to reach, we find ways to reach them. And we need to start thinking that they are underserved and underrepresented, which is a culturally safe way of thinking about it, rather than perpetuating a bias by saying they're hard to reach, because I managed to reach them. I managed to find every person that was on my wish list. And then I did a activity with some amazing service design students and wanted to understand them. And for each of them, we filled in a presentation slide like this. So we did what was important to them, understanding who and what was important to their pregnancy and their journey to birth and postnatally. And then we gave them options around, if we were to have a hub, which location would be ideal for you, what makes it accessible, you know, what time of day would sessions be good for you, do you have chores at certain times, you know, if you need interpretation services, if we're to run literacy, you know, antenatal mutual learning sessions, then, you know, do we need to have interpreters, do we need to have them in different ways, do you know, like language specific, or can we get multiple interpreters in and sit them in different types of rooms in different areas, or how do we do this basically? And we help them plan it. And you know what, if you give people a problem, they will often solve it themselves and give you the answers. And they did. And we launched a community hub in that area, and we developed a antenatal and postnatal MDT learning sessions for them. So the physios were going to lead on the aches and pains in pregnancy, antenatally and postnatally. The health visitors were doing safer sleeping and postnatal. We had lots and lots around mental health, because women and people from that community really wanted mental health and had various concerns around mental health and bonding. So we had clinical psychologists, perinatal mental health midwife, and various other professionals, the bonding specialist, all putting together sessions catered to them. And that was, you know, ready for them, based upon them, and co-produced with them. But in those sessions and those focus groups, COVID was very real and happening, and things were coming up. So I was working with a regional team, and we co-designed and produced a key maternity safety information, which is translated in 11 languages, and videos have been made as well, which have been used by community teams to share that. They cover some of those topics there that you can see in the bottom corner. And also, vaccination hesitancy was becoming very real and very evident. So I had an impromptu question around vaccinations, and we had a full-on conversation about why the hesitancy was there, what the fears were, what the misinformation was, and how we could address this. And based upon the back of that, we co-designed a vaccination drop-in information clinic, and we said, let's just talk it over. We had multilingual members of staff, and actually we had the opportunity for them to be vaccinated on site, but there was no pressure at all. And we were clear to say that. And actually, everybody, apart from two, everybody who attended that day was vaccinated. And about 90% were from Black, Asian, and diverse ethnic communities. And about 60 to 70% had a language barrier of those who were. So, you know, we were able to support them because we were in communication with them. And so that's why co-production is so important. I've done some work around co-production of digital healthcare as we go forward, because I know it's getting more and more likely that we're going down this pathway. But in reality, what is digital access, and how is this affecting various groups? I had a few focus groups with with professionals, actually not healthcare professionals, but just, you know, second, third, and subsequent generation health professionals. I'm so used to saying health professionals that it keeps coming out of my mouth, but professionals. So they spoke English, they were fluent. I also had a session with people who didn't speak English, and we found that there was unanimous concerns around, you know, IT systems and literacy, digital literacy. The fact is, everybody knew somebody who didn't even have an email address. There was concerns around algorithms that were flawed to look at Eurocentric the Eurocentric lens. For example, if we talk about the pulse oximetry, that is more likely to over predict oxygen levels in people with darker skin tones. And it's similar that these kind of things don't understand or have cultural nuances in them embedded in the algorithm, so the AI is biased as well. There was concerns around the lack of face-to-face interactions, because in some cultures communication is more body language focused. So there was a lot of concerns regarding barriers that would prevent recognition of issues when it's already quite hard for these marginalized communities to get support. Everybody had certain members in their family that they knew who couldn't rely on anything that was coming to them and couldn't read anything that was coming to them because they didn't speak English or read English, and things were still being sent to them, either text messages or letters were being sent to them. One person, and I've got a quote there that says, "Without my children, I wouldn't be able to access any services these days," which is really hard to read. And the final thought there, I'm just going to leave that with you, is shall we adapt the services? Shall we adapt to the services, or should the services adapt to us? So as we go forward, I just wanted to add this slide in because I think it's important that as we move towards the digital age, we don't forget that digital exclusion, digital poverty, digital literacy is something that's going to impact care, maybe a future barrier if we don't have co-production from the beginning. So some of the times my jobs has been in the NHS, and I'm trying to work and address those issues with the NHS. I've recently started a new job as a midwifery educator, but outside of the NHS, I knew the NHS was doing its best to evolve as quickly as it could, but it's a slow process. So I am a co-director of Association of South Asian Midwives, where we support midwives. We support health professionals to understand barriers that are faced within the communities. And we also support our communities to overcome some of those taboo, stigmatized issues like infertility, loss, mental health. And we are growing to be able to support them. We run a training around cultural safety and perinatal mental health, so how to be a culturally safe perinatal mental health practitioner. And we support research as well to make sure that those voices are not being silenced or erased as they have been traditionally. And my other organisation is Sheffield Maternity Cooperative. We support groups of people. We have a branch that's called Community of Cultures, which has specifically sessions for Black and brown bodied people, pregnant people and women. And the sessions are led by representative health practitioners focusing on advocacy. We run the sessions with co-production because we, let them tell us what they want sessions to be on. So the first session ever that we had was around mental health, and was around bereavement, then it was around mental health. But we have high attendance, and it is digital. If people are unable to access digitally, we give them data where we can and support them to attend. And these sessions are free, and they are funded by the Cultural Safety and Competency Workshop we run. Because we're a not-for-profit, we want to give back to the community. Me and Hannah have designed a cultural safety and competency workshop. So if all of that stuff I mentioned earlier didn't quite understand, feel free to reach out and consider joining one of our cultural safety and competency workshops, where we go into it for much longer and much deeper. And when you're next looking at designing or quality improvement project or research or whatever your field is, if that's students, if that's mentorship, that's training, always look at what may be there as a potential bias. Because until we are culturally safe, aware, and addressing those, it's going to perpetuate, it's going to continue. I want to thank you, and I want you to remember to always ask who's not at that table, ask why they're not at that table, and then go and reach for your tools, because sometimes the table wasn't built right and we need to rebuild that table. So I'm inviting you all to go and find some tools, and let's rebuild these tables. I'm not going to give a reference list. I will share some books for you to read upon your leisure, to, break that echo chamber and see how life is experienced by different groups in our society. Thank you so much. It's been a pleasure.
Sorry, just realised I was on. Thank you. Wouldn't be a Zoom without it. I think we are actually joined live now by both of our speakers. If we want to, if they want to pop up, let's have a look. There we are. Hello, hi Venus. Thank you so much for joining us. Thank you again for your wonderful presentation, and it's wonderful to see you live with us today. If anyone wants to put any questions in the Q&A box, please do, or the chat box, but we're having lots of thanks coming through. We're running shortly out of time. I do have a couple of questions here, so let me just get those now. Bear with me. Okay. Here we are. So I think this is a question for both of you, actually, that's come through. You've both been talking a lot about multiple, I can't even speak today, sorry, multiple factors impacting on weathering, so housing, access to news, persistent microaggressions. It's an enormous task to tackle these all. So what could practitioners do on an individual level, and then what also could we do on an educational level to start to make the right changes?
So for me, it really starts with listening to people. So depending on your role will depend obviously on the level of engagement that you're going to have, but the first thing you need to do is to start to listen to people, and then from there you can build a picture. For example, Benash spoke about her personal experiences, but as was highlighted in my presentation, but also just seeing out my own experience, I don't experience life in the same way as every other Black woman. I have a very specific experience that's unique to me. So the coming together of different voices and understanding those people's experiences and how that impacts their ability to engage with healthcare, and understanding their experiences, that's going to help us to make sure that the service is designed with people in mind who use the service.
Yeah, thanks. I think Natasha said that beautifully. I always go back to three things: making sure everyone's being heard, seen, and respected. Because if you can see everyone and you're listening, you're being respectful, and you are seeing the person in front of you, you're not listening to respond. You're not automatically formulating what you're going to say. What you're doing is you're absorbing what they're saying, and you're truly giving them the attention and interest they need. They will feel more comfortable with you, and that is what it is, taking that power balance away and putting a balance to that interaction, opening up relationship and building the trust. If you can do that, it's amazing. We talk so much about focusing on needing to have awareness. We can't understand everything, but one thing we should all understand is that we have differences, and we can be respectful to everybody. And if you're respectful, the other person feels that.
Sorry, you'd think after 2 years of being on Zoom, I'd have realised how to unmute, but anyway. Thank you. I hope that answers your question. That was wonderful. There's another one for Benash. Let me just have a look. Where has it gone? It's just disappeared here. Well, actually, one of them for you, Benash, is actually someone who's tried to book your cultural competency course through SMC, but apparently the link is old and doesn't work. So there's someone who would like to join.
Just email them. Email them.
Email them. Perfect. Another question for yourself as well is in relation to the systemic problems with cultural competence, and some of the issues are clearly extremely complex problems, but what are some seemingly fairly easy ways to address this, such as interpreters and allowing time to have interpretive conversations? Where is a good place to start educating ourselves on cultural competence then?
The most important thing is for you to be sensitive, and cultural sensitivity is not just about one culture or one thing. It's looking overall at what is impacting the way you give care, and if we don't recognize what's impacting the way we give care, we can't then challenge the systems. We can't say this system isn't working for everybody, therefore this system needs to change. The reason continuity works, it allows you the freedom to be able to have length and time and give people the time they need, work in a way that works for people, understand it, and because you know how that person needs their care, you're able to give that each interaction you have. That's the reason continuity has historically been able to help and support in the times when we're not able to deliver continuity, because at the moment there is a challenge with continuity. Then it's, as professionals, instead of firefighting, because we get so blinkered in the day-to-day of just trying to complete our clinic and get through the end of the day and see everybody, we need to take notes about how long it's taking, what we haven't been able to do, and audit it yourself. If you can write things down and say, in the last month, I've had 12 clinics and X, Y, and Z has gone wrong for this person, that person, that person, and I needed this, this, and this, and then you take it back, then those resources will need to be provided by your system leaders and your team leaders and the senior leadership team, but they don't know everything because they're looking at it from their perspective, until we are saying, look, these are the issues, these are the resources that we need, and this is what needs investment, and I can prove it to you because X, Y, Z, A, B, C. They're not going to know, they're not going to be able to invest, and they're not also going to be able to look how we plan as we go forward.
Thank you. Thank you. I think that should be it, actually. Oh no, there is one more. In relation to continuity of care, it seems a bit hit and miss depending on postcode. Can a woman request it? Is it something that can be more easily spread across the NHS, or is it again the same old resources and financial considerations?
I know from conversations this has been a challenge. It was always a challenge from the very beginning that it was recommended, and then we've had a global pandemic and a massive loss to the midwifery workforce, with continued awareness and worry regarding how we move forward with where we are presently. And really, true continuity isn't feasible until we have adequate staffing, and it's being offered in areas where it's needed. Originally, when continuity was planned, people automatically went for easy targets because it was a target. So they started providing continuity to people who had better outcomes already, or were already getting the stuff they needed. So it wasn't actually appropriately done just because it was, depending on who the senior leaders are and what their lens they were looking at it from, they didn't understand why it was recommended for certain groups specifically. So now there is intention to do that. We all need to ask the questions and hold our providers accountable to doing that. And we also need to be aware that when we can ask for it, we can advocate for ourselves, we can ask for it ourselves, we can say, have you got continuity? I would like to book into the continuity care plan. It might not be in my area. Why isn't it? When is it going to come up in my area, etc., etc.
Thank you. Thank you. And again, a huge thank you for you to joining us live. So thank you to both Natasha and Benash for speaking to us today. Incredibly informative and thought-provoking session. And thank you all again to those attending and watching back later on in the recording for attending and supporting us throughout the entire series. I'm incredibly sad it's over. We've heard from so many wonderful speakers on such important issues, and I really feel that we've all been able to contribute in helping raise all important awareness and education in racial inequality in maternal healthcare. All of your support and engagement has been incredible. We will be sending out feedback questionnaires, which will be most grateful if you can complete, just so we can improve on any future events. We will send out the recordings. We will be on our website. And we thank you once again and wish you all a farewell. Thank you and goodbye.